Hi everyone, welcome to the Q4 2020 Protocol Update CE. My name is Levi Hale. I'm the Clinical Education Coordinator with the Office of the Medical Director, and I'll be taking you through the bigger changes that occurred in the new protocol update. Keep in mind that though this section is short, the content presented here is no less important than you saw in the other big sections of the protocols. The reason it's so short is because there's just not quite the same number of changes in pediatrics. And so I'm going to cover the higher level topics that did occur that were above and beyond the simple dose change and things of that nature. So to start off, the first major change to the pediatric section was the addition of bronchiolitis as a condition that differed in treatment from the other causes of respiratory distress in pediatrics. Bronchiolitis, for those of you that aren't familiar with the condition, is just like what the name suggests. The bronchioles are a branch of the lower airways that exists just before the alveolus. And it's an inflammation of this part of the airway. This condition is something you should suspect for patients that are having respiratory distress, that are less than 2 years of age, and are having wheezing with some form of viral infection. So what you'll be looking for there symptomatically would be fever, sinus complaints, coughing, things that suggest ear infection like tugging at the ears or inconsolability, those sorts of things. The big difference between bronchiolitis and asthma is that its origins are different. So bronchiolitis results, at least in part, due to the patient's anatomical differences from adults. So younger patients, as with most things in the body, tend to be more flexible, and that applies to their bronchioles as well. This results in some propensity to wheeze. If there's respiratory distress, increased work of breathing, anything like that can trigger a wheeze in a patient, especially the closer they are to being a newborn. As a result of this, asthma is generally, or the diagnosis of asthma is generally not given until the patient gets beyond the 2-year threshold. So it's really just not a thing for a patient to have a diagnosis of asthma if they are under 2 years of age. So we know a little bit about what bronchiolitis is. We need to know a little bit more, though, about how a typical bronchiolitis case progresses. And so rest assured that bronchiolitis patients, for the most part, are treated and discharged from the ER. And for the vast majority, they do not require admission or ICU, intubation, any of those big scary things that we're not as comfortable doing with pediatrics. The flow of a typical bronchiolitis case is generally over a relatively long period of time and is associated with their infection. So generally speaking, they're going to have symptoms from the time they get the infection until they're over it. So for the majority of cases, we're talking 7 to 10 days, but this can go upwards of a couple of weeks. And with that, the symptoms generally peak at around day 3 to 5. The biggest symptom that you should look for when you're taking your history at this point is a persistent cough. So we've got a good background on bronchiolitis at this point. So what exactly are we doing differently? So mainstays in treatment with asthma include bronchodilators, so albuterol, ipratropium, things to control the secretions, right? We're treating the disease and all of the symptoms it causes. And then we also give steroids to decrease inflammation. So the biggest difference in treatment is that We now know that this condition is not asthma. So even though it looks a lot like asthma, we have wheezing and we have respiratory distress. We're not going to follow the same treatment that we would with adults for asthma. So the reason we're not going to administer inhaled bronchodilators is primarily that it doesn't really improve the patient's condition in this age group. The bronchodilators just don't add a whole lot to the resistance of breathing and or alleviation to the resistance that the patient is experiencing. And we also can trigger a bit of a falsely elevated heart rate. The problem with that is that raising the patient's heart rate pharmacologically due to the albuterol causes a bit of confusion when the patient gets evaluated, say, for sepsis. So the albuterol triggers an increase in heart rate because they get a little bit of beta 1 crossover effect, and then that may potentially put that patient into or beyond the normal heart rate threshold. And then that in tandem with other criteria, and then the patient may end up receiving a lot more treatment than they don't necessarily need, and may be getting set up to get things like lumbar punctures and other invasive care that wasn't necessarily indicated. Additionally, we're not going to give steroids for bronchiolitis because what they found in studies was that bronchiolitis wasn't, with the patients with diagnosis of bronchiolitis, there wasn't an improvement in their hospital admission rates or their length of stay in the hospital. So there's no efficacy for administration of steroids for bronchiolitis. There may be some situations in which treatment with the standard treatment for wheezing may be appropriate, one of which includes patients that have had a similar history that was resolved by that course of treatment. So generally speaking, this would most likely be patients that are on the older end of the age criteria. So patients that are closer to 2 years of age and they've had a similar episode in the past and was treated with bronchodilators and steroids, and the patient had improved that time. This suggests that there's a greater probability of an asthma process in play here, as opposed to simple floppy airway contributing to the wheezing. Another situation which may incline you to follow the typical treatment for wheezing would be patients that have history of eczema or other inflammatory disease. Eczema, for those that aren't as familiar, is the condition where they have dry, patchy places on the skin that is the result of an inflammatory process. The image you see there is a great example. That and other sorts of inflammatory type diseases or history of a lot of different allergies may suggest that treatment under the normal treatment pathway for wheezing may be appropriate. So what do we focus on when we have a bronchiolitis patient? We're not doing a lot of the things that we're used to doing. We may feel a little out of place. And so what we should focus on primarily, especially with patients in the younger end of the age criteria, so that's newborn up to 2 years, but the younger end of those patients, we should focus on suction, and then also add saline flushes to the nares as well to keep the airways clear. About 50% of your airway resistance comes from the upper airways. And this is even more important in infants because they are primary nose breathers and their airways are much smaller in general. Again, the big piece of the bronchiolitis equation is having viral illness, so there's going to be a lot of secretions, and management of those is critical. Additionally, keep in mind that with treating any patient, but especially patients that are suffering from infections, A patient that feels well heals well. So we want to focus on good supportive care. So we've got a fever protocol, use it as appropriate. Remember that respiratory distress increases your respiratory rate. You've already got a lot of secretions, and so you're losing a lot of fluids through evaporation and secretion. So rehydrate that patient and just keep them generally consoled to make them feel better, because that's going to improve their recovery. Lastly, focus on protecting yourself. It is the season, and we're dealing with a global pandemic. We don't really know how much infection of COVID-19 is the cause of this condition at this point. It's a brand new disease, and so make sure that you're wearing your PPE and that you're protecting your other patients by appropriately decontaminating your unit. So that concludes the changes for bronchiolitis. If you have any further questions, please reach out to us. We're happy to discuss it. The next big topic to discuss as part of the pediatric protocols is a condition called a brief resolved unexplained event, or BRUE for short. This is a condition that was formerly known as ALTI, some of you may be familiar with. And essentially what this is a condition of something that scared the caregiver, that was unusual, that prompted a 911 call. So the definition of a BRUE is a patient of less than 1 year of age. They had a sudden, brief, resolved episode of breathing abnormalities. So they either stopped breathing, they weren't breathing very deeply, or they had some sort of irregular breathing episode. They had a color change, so they either became cyanotic or lost color. They either lost muscle tone or had some seizure-like activity that scared the caregiver, or they just had an altered level of consciousness. Highest risk kids in this category are those that are less than 60 days of age. They were premature at birth. They had any CPR by a trained provider. The event lasted greater than 1 minute, or this has happened before. Avoid the temptation to give in to confirmation bias here. We see a lot of these type of incidents over and over again, and we tend to attribute them sometimes wrongly to possibly a new parent that's unfamiliar with the behaviors of a newborn. And the protocol change that we're discussing here specifically addresses what we should do in response to that. So as far as care goes, we're going to thoroughly assess and monitor this patient. We're going to strongly advocate transport to the caregiver. Again, we don't want to attribute this wrongly to a condition that is benign and then misinform the parents. Keep in mind that certain patients are at risk for SIDS, or sudden infant death syndrome. What we need to report in these situations requires an eye for detail. So we need to report the quality and the duration of the symptoms that happen during the event, before the event, and after the event. This includes the color, the tone, the breathing, how the patient feeds, the position, activity, and level of consciousness. We also want to include whether or not there was any resuscitation efforts, especially if they were performed by a first responder. We also want to include whether or not the patient was born premature. So that concludes the changes to the pediatric section that required further education. If you have any further questions, don't hesitate to reach out to us. Again, my name was Levi Hill. Thank you for being with me.